Shake them all out. Okay. Welcome to Mindset and Muscles with Amanda. I'm your host, Amanda Ferlisi. Welcome back to our physical therapy series with Garrett. Let's jump right into it. Garrett, I feel like I haven't talked to you in what seems like 3 months. I don't know. Fill us in. How's the baby? How's your wife? How are you?
I mean, it's chaos in the house for sure. But the little man's doing well. He's slowly sleeping better, and we're gearing ourselves up for the regression that we know is coming, that we've heard all about. But yeah, he's getting more and more expressive, smiling a ton. He's like babbling and cooing, which is great. Him and the dog have become best friends, so that's a plus as well.
That's adorable.
Yeah. Otherwise, things are going well. My wife is still recovering. She went through a lot, obviously, with childbirth and with me getting back to work and us trying to ramp her up, and her by nature of just kind of the way things fell. She's been a kind of the primary caregiver for this first stretch.
Mm-hmm.
I think she's feeling it, but I think she loves the kid, he loves her, and I think she's definitely a natural when it comes to kind of the interactions and kind of structuring the day to make sure he gets the right stimulus and everything. So it's all good stuff.
She sounds like Superwoman.
We're both just kind of happily sleep deprived right now, but overall good.
Awesome. So I did want to bring up, so I didn't post, typically I'll post like a Q&A on my Instagram, get some people's feedback, but I wanted to ask some clients some questions, and a couple questions that actually came up that I think are super beneficial for everyone in the personal training world. If you're a client, if you're a trainer, if you're a physical therapist, I think it would be beneficial to discuss this pretty in depth. So a lot of people don't know what a pulled muscle is, if it is the same as a strained muscle, how to work out with it, don't work out with it, all of that. So what we would like is for you to explain what a pulled muscle is and just break it down like into simple form so we can understand what it is and how to recover from it.
Yeah, of course. And it's one that I think physical therapists and trainers get a lot of.
Mm-hmm.
I think that a lot goes into a strain or a pulled muscle. First is identifying the severity of that dysfunction. With contractile tissue, you're looking at strength versus weakness and pain versus no pain. So on the most severe, a completely ruptured tendon or muscle will result in no pain and weakness. So if you rupture your Achilles, a lot of people report kind of feeling like they got not shot, but they got like punched in the back of the leg, or the biceps tendon going will be kind of a jolt through the shoulder, but then it's pain free. There's just no function left in that muscle. So that's obviously on the severe end of things. On the less severe end of things, you'll have pain, but it'll still be strong. So just kind of looking at those parameters, you'll be able to kind of tell where you are at, where your healing process should begin, and that will give you the direction in which to program the right interventions or exercises and kind of facilitate the right healing process.
Can I give you an example just so it's easier to like go by?
Yeah.
So I'll just use like a pulled right quad. So can we use that for like the example going forward? So say my client pulled their right quad while lunging. So explain like what that actually is and how to go about the process of recovering from that.
Yeah. So I think I have some follow-up questions.
Mm-hmm.
It was that right leg in front during the lunge, or was it in the back?
In the back.
In the back. So this client was stepping forward with the left leg,
Mm-hmm.
and that right quad strained.
Correct.
Okay. So I think in that position, the first question obviously would be, I would have them describe the pain, the quality of it, on my side of things, we want to rule out any type of neurological issues. So
Mhm.
the locality, the localization of the pain, the specificity of the pain, and people can tell when it's a muscular type pain. Nerve pain is very distinct. And if people are questioning whether it's nerve pain or not, I'd say by and large, it's not typically nerve pain. And then, we'd run through the tests once we get the quality of the pain. Well, you check range of motion, you check muscle strength, you check postural assessment, and just kind of the way the patient likes to position themselves will tell you a lot as well.
Mhm.
So in this specific example, that right leg was in a position theoretically of hip extension.
Mhm.
Um, so at the beginning or at a baseline, I would make the assumption that when that quadricep was lengthened, there was a lacking tolerance to that lengthening. Because that when it comes down to it, a strain is really that individual's inability to tolerate that stress at that given time.
Okay.
So it's not, I've had clients and patients come in say that they have micro tears of this tissue, or they talk through the very specific, almost cellular level damage. And, that's present in all strains. And short of a complete rupture, and even a complete rupture in certain populations, the biceps tendon is not repaired. But short of a complete rupture, like healing can occur. It just depends on how long of a time frame we're looking at. But for your example, with an active individual who's exercising, who's presenting with right quad pain with a left leg forward lunge,
Mhm.
I would be looking at the way they like to carry their hips, the way they like to carry their ribs and their trunk. I would obviously test the quad strength. I would test the glute and hamstring strength as well. And then I would want to try and through an interview, tease out whether this is a quad, whether this is a hip flexor, and then get more information about how the pain presents with movement. So do they have pain while they walk?
Yes.
Okay. Is it more severe? Like, what about stairs?
It hurts more when they bend their hips. So they can put pressure on it like a little bit and be in discomfort. But when they're walking up the stairs, it hurts more walking down the stairs. And it hurts to do any like sitting and then standing up. But just standing straight and walking forward is fine.
And when they're walking, it hurts when the left leg is up in front still, or does it hurt when the right leg is in front?
When the left leg is in front.
Okay. So it could be a number of things in this specific case. It could be you have one of the four quadricep muscles attaches across the hip and at the knee. That would be the rectus femoris, which is a potential candidate for what's going on.
Mhm.
It attaches right at the point of the pelvis. The technical term is the AIIS, and then runs down to the patella, and then into the patella tendon. That is a potential contributor. The other one is the psoas or the iliacus. Anything in that region could be a potential contributor to this pain. And getting too deep into the details is always what us physical therapists probably do too much of. Because when it comes down to it, the best treatment is, in my opinion, repositioning and then building tolerance in previously painful positions. So, if anyone's listened to this podcast before, I'm going to go through the same kind of shtick when it comes to repositioning. But everybody should be able to stack their ribs on top of their pelvis. And, that's the basis of squat training. It's the basis of deadlift training. It's the basis of, even any type of press, you need to be able to develop tension through your abs, and you can't do that without the ability to stack your ribs on top of your pelvis. With this specific example, there's no reason why a normal adult person cannot do a lunging movement without pain in the back leg. So I think it's challenging without the person right in front of me, but I would likely try and inhibit musculature that is overactive, which would likely be the low back muscles, likely be the hip flexors.
And how would you do that?
So at the very beginning, at the most basic level, I would have somebody laying on their back, feet either up on a wall or in what we call hook lying, which is the knees bent to 90 degrees but flat on the floor.
Hmm.
I would have, excuse me, either a yoga block or a ball in between their knees. And then I would cue an inhale through the nose and exhale through the mouth, trying to get every bit of air out of their lungs. And as they do so, feel their back pockets come up towards the knees.
So raise up like a glute, right?
It's basically a posterior pelvic tilt, but you're
Okay.
cueing it in a way that is facilitating the hamstrings to do the action rather than the rectus abdominis, which is very much a sagittal plane muscle, doesn't do a ton for stability.
Hmm.
So we need to get those obliques involved, which is a big component of rib cage depression and internal rotation, which is where we cue the exhalation.
Hmm.
Coordinate that with a hamstring activation to get the tailbone underneath you. And that takes that tight hip flexor and puts it into a position where it doesn't have to fire. And it takes the low lumbar paraspinals, the muscles in the low back, and puts them in a position where that doesn't have to fire. So I'll cue that a handful of times, first just letting them go through the movement with breath, and then
Hmm.
eventually having them maintain that position with breathing. Because what that will do is with each inhalation, if that position is maintained, we'll attempt to drive expansion into the space where those muscles were previously compressing. That further enhances the inhibitory effect of those muscles. And then from that position, there's honestly limitless combinations of things you can do. There are, yeah, in the PT world, there are a lot of different schools of thought that have a lot of different exercises in that position that are based in a lot of different pattern movements, that sometimes make things complicated for the client, but other times it's simplifying things really, especially with a lot of the clients that we see and a lot of clients that I'm sure you see. Just like generally cleaning up their position and their ability to get throughout a position is going to be beneficial.
Okay, I have a question about this. So basically, in what you're saying is, we'll say Barbara, that's the client, pulled the quad. So say um, that happens during the session. I just walked you through what happened. Now, where it becomes like it not iffy, but like I get nervous, and it's probably going to be like I always get nervous. I don't want anyone to get hurt, right? The client is like, oh my God, this hurts so much. And they get scared. Like a lot of people instantly are like, pain, I'm scared. So in that moment, what you would say to Barbara, if you were me, is to just lay flat and walk her through that those exercises to engage the other muscles as opposed to the quad. Is that correct?
Yeah, and I think you hit a big point of the strain, is that there's a pretty significant mental component as
Mm-hmm.
well. When somebody feels that they are not operating the way they think they should or the way they think they're capable
Right.
of, there's a certain hesitancy which kind of inevitably leads to more dysfunction. So I think if in the moment the clinician or the practitioner can show that there is a way to relieve, at least taking the edge off the pain is just as valuable. Giving that client some control over the pain would allow for that session to continue. Um, so that's personally what I would do. I would start off with that. I would start
Okay.
off with um, having them laying flat on the ground, feet flat, knees bent, something in between the knees,
Mm-hmm.
work that posterior pelvic tilt cued with breathing. And then I would be cueing the hamstrings and the obliques to make sure that everything is firing the way I would want it to. And then we could go a number of different ways. There's a couple good hip flexor stretches that aren't really the traditional hip flexor stretches where you're really cranking into the end ranges of those movements.
Mm-hmm.
And then there's some strengthening concepts that you can tie in, which would be basically strengthening the hamstrings and the glutes,
Mm-hmm.
um, in a way that takes that hip flexor out of the equation and allows for other muscles to do the task the hip flexor was previously doing. All of those things, none of it's going to solve the problem right off the bat, but
Mm-hmm.
what it will do is give the client some actionable items that they can have moving forward that, if they're standing up from their desk at work, they can do something to kind of reduce the pain. Um, and then once you've addressed the immediate acute pain, as well as kind of the stress and the fear that goes along with this new pain,
Mhm.
then it's basically taking training and knocking down the intensity level, maintaining the big movement patterns that you're going to want to hit in any given session,
Mhm.
and just programming effectively. um, you're taking squat training back a few steps, you're taking deadlifts back
Mhm.
a number of steps, maybe go back to the like a heel on the wall type of RDL, or a heel elevated slow goblet squat,
Mhm.
things that allow for, take away some of the extra complexities of the traditional movements. So you're providing stability just based on your own programming to
Mhm.
take away the pain and continue building strength in these movement patterns. And then as you rebuild, you're exposing them to more and more stress in this newfound position, which will also result in more resiliency, injury prevention, and quite frankly, a more efficient workout.
I actually just thought of like 3 other more questions that I have to ask you, but okay, so that being said, I think when I said, like, people get super scared when they're injured is it's just normal, and to just turn off that muscle and help, engage the other muscles to strengthen them. And then now so you've used pull and strain interchangeably, so can you clarify that those are the same things?
I mean, that's how I see them. I
Mhm.
think there's, a pull. A pull typically is when somebody's self-diagnosed. They'll
Mhm.
come in and they'll say, "Oh, I pulled my hamstring.
Mhm.
Oh, I pulled my quad," and then a strain would be they've seen the doctor. That's completely anecdotal. That is not official. That is just on the population that I've seen. But the pull versus strain seems to be either how much extra input they have been given to their diagnosis.
Right, and do you see so I have the ages of my clients range from 20 all the way up to right now 68, and I always notice that certain age ranges cope with pain differently as far as, "Oh, I'm not gonna move. Like, I'm not gonna do anything. Amanda, I hurt this, I'm done." And then I have clients that are like, "Oh, I'll just take some anti-inflammatory medicine." And then I have some that are like, "I'm just gonna keep going until my body gives out." Do you see the same within what you do?
Oh yeah, 100%. And that, I mean, the mental, because honestly, the physical side, the science behind a pull, everything all the way down to the cellular level,
Mhm.
like that prescription of interventions is variable based on the presentation, but it's kind of a defined subset.
Mhm.
The mental presentation is wild. I mean, it's, you have your one client who comes in and is walking normally and is complaining of 10 out of 10 pain, and they can't do anything, but they also went to whatever practice or whatever workout class or whatever activity they had before, but it's just taking up so much real estate in their head that their perception of their injury is very severe. And then you have another client that comes in that might actually be limping and might actually be experiencing a lot of pain, but they just they report a 2 out of 10. Um, and their perception of pain is just kind of like, oh, all right, well, this is what it is for now. And I'm not gonna waste too much time thinking about it. And both are valid, both present different challenges.
Mhm.
But I think as a clinician, you kind of have to read the room. That's where those soft skills kind of come into play, where you read the room, you kind of see what gears are turning, and I guess how much gasoline is being thrown on the fire, and then try and address things accordingly. And I think the hardest component is that, because once you get on top of that and they feel like they have control of their pain, then it's just a programming question. And then you get them out of pain, and eventually, you might change up your program a little bit, rather than doing, if they have that pain in the front of the hip, maybe stay away from any type of deep hip flexion or hip extension moment.
Mm-hmm.
Uh, maybe change my finisher for the session, or change how heavy or how intense they're going, take a timer away, have them do some tempo work. Um, things that give them some confidence in that structure without overly stressing the tissue.
Okay. Because I just feel like I feel like me personally, I feel like I have a really high pain tolerance. And then when something hurts, it's like, it hurts. I need to fix it now. And then again, like I have clients that will like be like, oh my God, that hurt my shoulder so bad. I'm like, I didn't even know it hurt you. You made no indication that that hurt. So it's interesting to see that, because I feel like in what you do specifically, you really need to be able to understand what their pain level is to program like how to rehab them. So
I
my
think
other, hmm?
that's sorry. I just one last point.
Yeah.
I think both in the training and coaching, as well as the PT world, there are a number of different ways to get after the same goal, right?
Mm-hmm.
So if say the lunge bothered them, if the lunge bothers them and I do my initial techniques to reduce the level of the pain, and then I don't return to a lunge, but I return to something else, whether it be a lateral step up with a hip shift, or um, working a single leg hinge type position, and there's no pain, then you can kind of start having the conversation of like, look, I understand the lunge bothered you. This is the same movement pattern. This is the same type of goal that we wanted prior. And the fact that there's no pain is a good sign.
Mm-hmm.
So, we can take lunges out. There's a number of other things that we can do, but we'll start working through this to get to the same goal. Again, it's just all about giving the client control.
Right. So another question that I have for you is what should you do if you have sore muscles? Now, I'm going to break that down a little bit. So say I just change up my programming and intensity, whatever it is, and my legs are super sore. A lot of people are always like, well, I'm not going to work out. I'm not going to do anything because my legs are sore. What do you recommend, and what specifically is causing all that muscle soreness?
I mean, there are a couple things. I mean, the most, I guess, obvious explanation is you have a buildup of acid in the muscles,
Mm-hmm.
byproduct of the work. It's normal.
Mm-hmm.
It should go away pretty quickly within a couple days.
Mm-hmm.
Um, there is something called DOMS, which is delayed onset muscle soreness, which is a little bit more severe and might kick in a day or two afterwards. And then it's up to the clinician to read that client, kind of understand ahead of time what their relationship with pain is like,
Mm-hmm.
and then program accordingly. Because say somebody was doing Pat Davidson's 30-30 workout, which is 3 rounds of 10 exercises, 30 seconds on, 30 seconds off, 15 reps, and you're going for pure volume. So you're putting as much weight through this program as you can.
Mm-hmm.
um the if they come out of that just absolutely torched, in that program, that's kind of the goal. But B, if especially at the beginning of the program, you can start playing with where you're putting that weight. You can start playing with where in that program is the most volume going.
Mm-hmm.
um so I think it's really just it's figuring out what the relationship with pain is like, and then changing the variables that you have some control over in order to still give a good workout and still keep people moving. Because when it comes down to it, not doing anything is going to make it worse. It's just going to be more uncomfortable. So some kind of movement, some kind of exercise is always good. And whether that be tweaking the weights of the existing program or knocking things down completely and changing gears just for that session to make sure that you hit the targets you're going for, there's still value. But I would say anything besides just nothing is probably your best bet.
Thank you for bringing that up. So I have a lot of clients and then some family members and just in general that they're sore specifically. And I know you can go down a rabbit hole about back pain, but again, it's back to the whole, I'm in pain. I don't feel like doing anything because I'm in pain and it hurts. I don't want to make it worse. So Can you explain why it's not the best option to not do anything and to sit still, rather to you should go work out and rehab that? Can you explain why that's so important? Because I feel like so many people need to hear this, because even when I'm in pain, I still work through it. I do my, exercises, ones that you've taught me and things like that. Can you explain that, please?
Well, I think we're treating this conversation as pain after exercise.
Mm-hmm.
Um, so again, just to be responsible, I would want to tease out anything else that could be potentially contributing to the pain.
Mm-hmm.
Ton of nerves come out of the back. Discs are always talked about. Um, that being said, if you took an MRI of your average sample size of your average adult human beings, you would see discs bulging and nerves pinching without any symptoms in those individuals. So that's not always a 100% certainty that there will be pain if that's happening. Um, but if we're treating this as pain after exercise, that pain again is likely due to the body's inability to handle the stress that you were asking it to do.
Mm-hmm.
Once that pain kicks in, your body's in a defense position, which is to kind of tighten up,
Mm-hmm.
reduce any extra movement to reduce any potential pain. And that cycle is what's contributing to or perpetuating the pain. To reduce the pain, you want to work out of that cycle. So, an example that we have here all the time is somebody has, they might have pushed their deadlifts a little too much. The back starts to bother them. They come back in the next session, they tell us the back's bothering them. And I would say a lot of what all of us do will program at least some type of carry into the next session. Carries are much harder to screw up than a compound lift. It basically takes some cueing to get into the right position to begin with, to make sure you're feeling the muscles that are supposed to be feeling. And then you just carry something somewhat heavy for a stretch and back.
Mm-hmm.
There's 1,000 different modifications of carries. You can do it with, the suitcase carry with one arm, the farmer's carry with two, the waiter's carry, any combination. You can carry a trap bar, which is pretty beneficial. You can carry a trap bar and do lateral side steps. That's beneficial. But with back pain, especially after exercise, I would typically, again, that drops the complexity and intensity level. There's less moving parts across a range of motion. So there's less variables to control. So by targeting the right muscles, by putting them in a less complex position and movement, and then allowing them to move, you're kind of rewiring some of those patterns that are causing the pain.
Interesting. So I just want to put it out there that if you have any questions about that, ask Garrett, or you can ask myself and we can talk to each other about it. But it's really important that we bring up that not to just sit still, because that's very common. And again, has to do with fear of getting injured more, or just, I don't know. Sometimes I just feel like people say, oh, I'm in pain, and then they don't want to work out. But that's a whole motivation thing that we don't need to get into today. Um, that's all I actually had to ask you today, because it's been such a super common question. Did you have anything else you wanted to add about pulled, strained muscles, or anything like that?
I think I would just want to reiterate that when it comes down to a pull or a strain, once you get past the positioning component, it and most of strength training is all about load tolerance and load management.
Mm-hmm.
So anything where you're exposing yourself to increasing loads without pain is going to help the system cope with further progressions. So when you're in pain, doing the groundwork to begin with, but then, working with somebody that you trust is obviously a must. Getting the correct information is obviously a must. But then kind of falling back on the big movement patterns that we all need to do, and a lot of strength professionals love the most, of squat, deadlift, and press,
Mm-hmm.
is kind of a safe bet. And it's stuff that you can do at home. You don't need a gym. You just need the right coaching and the right cueing and the right kind of breakdown of sets and reps. So it doesn't have to be overly complicated, and you just kind of have to build the foundation enough to allow yourself to do that.
Absolutely. I couldn't agree more. So I just want to say thank you so much, Garrett, for coming on for another episode of our physical therapy series. And again, if you guys had any questions, and his information is below, my information below as well. And thank you so much for listening today, this afternoon, evening, whatever time you're listening to, and have a wonderful rest of your day, everyone.